Hello, everyone. I'm Dr. Carmen Puliafito, and today I have with me Dr. David Lally of the New England Retina Consultants, and we're going to talk about an interesting topic that has been controversial, which is the effect of AREDS vitamins on geographic atrophy. David gave a very interesting and comprehensive talk at the Angiogenesis 2026 meeting at Bascom Palmer Eye Institute. So we'd like to welcome David back to retina synthesis.
Thanks, Carmen. Yeah, thanks for having me back. Appreciate it.
So why don't you recap the key points of your talk?
Yeah, sure. Oxidative damage to the retina, it's been long suspected to be involved in the pathophysiology of macular degeneration. And so it was a natural place a while back now to try to supplement with antioxidants for patients to see if that would influence the disease of macular degeneration. And the landmark AREDS clinical trial, which was published in 2001, clearly demonstrated that supplementing with this AREDS formula of antioxidants was able to reduce the risk of patients that were in the intermediate stage of dry macular degeneration, reduce that risk of developing advanced macular degeneration. And that reduced risk was 28% at 5 years. And they defined advanced macular degeneration as including both either the development of wet macular degeneration or the development of central geographic atrophy. And we saw when we looked carefully at dividing up the advanced macular degeneration, did AREDS affect wet macular degeneration specifically? Yes, it did. It was very powerful, those supplements, at reducing the risk of wet macular degeneration. However, when we looked at did it reduce the risk of central geographic atrophy, it did not reduce that risk. There was no benefit seen with that original AREDS formulation. And they defined central geographic atrophy as atrophy developing within 2 disc diameters of that foveal center point through an assessment on color fundus photography. So that was in 2001. And then in 2009, a post hoc analysis was done on the AREDS trial, looking at did AREDS have any benefit to affecting the lesion growth rate of atrophy over time. And they did not observe any benefit with AREDS supplementation in affecting the lesion growth rate over time. So that was 2009. And then in 2012, we had the second AREDS study looking at the AREDS 2 formula, which showed that it was okay for us to swap lutein and zeaxanthine for the beta carotene that was in the original formulation, and it still reduced the risk of intermediate dry progressing to the advanced stage. And we looked at a post hoc analysis in 2013 that looked did the AREDS 2 formula have any benefit in either slowing the development or the lesion growth rate of geographic atrophy. And again, we did not see any benefit with the AREDS 2 formulation. So since 2013, the general consensus has been that AREDS supplementation has no treatment benefits for either the development or the progression of geographic atrophy. So most of us physicians were not recommending AREDS for that disease specifically. However, there were data gaps with this information that we had. And so, importantly, we know that incident GA develops 2/3 of the time in the non-foveal region outside the foveal center point. And we also know that GA, when it expands substantially slower towards the foveal center region, as opposed to how it expands towards the peripheral macula. And that's clinically meaningful to us or relevant when we think about the lesion growing towards the foveal center point, where when it gets into the foveal center, we know that's typically accompanied by significant vision loss. And so with this in mind, the AREDS research group, they went back and they reevaluated both the AREDS 1 and 2 data sets, evaluating the effect of AREDS supplementation on the growth towards that foveal center. And so, this analysis was just recently published in 2025. So this is newer data. And they looked at two different analyses, and they enrolled patients that were in the AREDS 1 and 2 study that had at least two accessible images over two study periods or more of geographic atrophy that was assessed on color fundus photography. And they did two analyses. The first they called the proximity-based analysis, where they measured over time the growth of the lesion towards that foveal center. The second analysis they did was an area-based analysis, looking at the change in the area of the lesions over time. And so what they found was that the AREDS supplementation had no benefit in slowing the GA lesion growth over time, and there was no benefit on preventing vision loss over time. However, we did see a benefit with the original AREDS formula in slowing that growth towards the foveal center 35% slower than if you were not on the AREDS supplementation. And then with the AREDS 2 formula, the results were even more impressive, where it slowed 35% even more slower towards the foveal center as opposed to the original AREDS formula. And so this was really interesting and important data that rocked our world in the world of retina when this came out, especially when we're thinking about our other treatment options for geographic atrophy, which are the complement inhibitor therapies that we use. And so now the question is, in 2025, is could these results that we're seeing with this 2025 AREDS research group publication, could they be replicated in other large data sets? And we have two good data sets that we can look at. The first is from the Chroma and Spectre trials, which were the pivotal lampalizumab trials that were done a few years ago. And this post hoc analysis looked at both the sham-treated arm eyes and also the treated lampalizumab eyes, and they assessed the geographic atrophy in patients who were taking the AREDS supplements versus who were not over the course of the trial. And they assessed it by fundus autofluorescence, the area change. And what they saw was that the AREDS supplementation had no benefit in either affecting the lesion area growth rate or the progression towards the foveal center point. The second large data set comes from the Oaks and Derby trials, which were the pivotal trials for pegcetacoplan. And in these trials, 40% of the subjects were taking AREDS at baseline. And specifically in this post hoc analysis, I should say, they were looking specifically at the untreated eyes in the trial, so not the pegcetacoplan treated eyes. And at baseline, 40% were taking AREDS. There was a good adherence to the AREDS throughout the study. I think it was 93%. And they assessed the area of atrophy and the distance from the fovea based on fundus autofluorescence imaging. And what they saw was that there was no benefit from AREDS supplementation on these untreated eyes in the progression towards that foveal center point, or in the area growth rate of the geographic atrophy. And that was regardless of whether the atrophy was in the foveal or non-foveal center point region. And so now in today's world, we're left with three conflicting studies that have conflicting results on what the role of AREDS supplementation can do for geographic atrophy. And so why do we have these conflicting results between these trials? And, the first thing to say is, well, all three of these trials are post hoc analyses. So they're not powered to detect real differences within the outcome measures that they're measuring. The other important differences is that there's differences in the imaging modalities that were used to assess the geographic atrophy. And we know that fundus autofluorescence imaging, it's more sensitive in detecting early atrophy development as opposed to fundus photography. And so that may affect the measurements that were performed. And then the final thing is that in the large pivotal trials of Chroma and Spectri and Oaks and Derby, these trials had much more frequent study visits, typically every 1 to 2 months, as opposed to the original AREDS studies that had less frequent treatments. And so we were able to collect much more data points that could be used in the assessments of these larger pivotal latter two trials. And so at this point, I think the data at this moment we would say is, or I would say is it's not strong enough at the moment to be recommending AREDS for my patients with geographic atrophy. However, I still think that there's data gaps here, Carmen, and I think we need to be exploring this further. Because if there is a way that we can find real true benefit and a consensus that we agree, this is a very easy way, that's very easy for patients to take, that may have a benefit for their for their vision over a long period of time. So that's pretty much, I think, sums up the talk there for you.
What about the chance of reducing neovascular AMD in eyes that have geographic atrophy and are being treated with a complement inhibitor? Can you speculate on whether or not the AREDS formula would help them?
That's a fantastic question. I think it's an important question. We certainly know that patients with geographic atrophy, that when they're on complement inhibition therapy, that there is a risk of developing neovascular AMD that's increased risk if you're as opposed to if you're not taking complement inhibition therapy. And that risk is somewhere 10 to 15%, at that first 1 to 2 years after you're treating with those therapies. And so would AREDS be helpful in once the wet AMD develops? I don't really know. Once it develops, should I put the patient on the AREDS? But to the point, that we saw in the AREDS 1 and 2 clinical trials, we know that in the intermediate stage of dry macular degeneration, it strongly lowered the risk of developing neovascular AMD. So, in this patient population that you're describing patients that have geographic atrophy at that baseline. Should we start the AREDS to prevent neovascular AMD? And I think I don't know, I think is the answer, and should we be thinking about exploring that? Absolutely, we should, because again, the risk on the complement inhibition therapy is, to me, 1 out of our 10 patients we start that therapy on 1 or 2 years later, they're developing the wet macular. And in the pivotal pegcetacoplan trials, patients that developed wet macular did end up with reduced visual acuity overall over time. So if there's a way to get ahead of that, if we make a clinical decision, I could envision a day someday where we have geographic atrophy. Maybe we're thinking about starting complement inhibition, but when we're starting it, we should also be thinking, should we start that AREDS? But I think those are analyses that I expect we're going to start to see over the next few years, and hopefully that will give us good guidance of whether we should do that or not.
Well, certainly in patients that have geographic atrophy in one eye and intermediate disease in the other eye, you would recommend keeping up the AREDS treatment, correct?
Absolutely, yes. Yeah, absolutely. Yeah, yeah. My patients, absolutely. If one eye has intermediate dry AMD, there's no question. I tell them, yeah, I want you on the AREDS. And I actually tell my patients specifically it's for that eye with the intermediate dry. I want to lower the risk. It goes to the advanced stage like your other eye, so I keep those patients on. And then it becomes a question of if the other eye does develop the advanced stage, what do I do at that point with recommending the AREDS? To me, a lot of people may feel, well, what's the harm in just prescribing AREDS for everybody, and to me, AREDS does have some drawbacks to it. What are the drawbacks I see in my practice? Well, the first would be the costs associated with it. They are not inexpensive medicines for a lot of my patients. And my patients, the other thing would be my patients a lot of times in this population are taking a lot of other medicines. And now I'm asking them to take two more pills per day. And these pills can be, my patients tell me, large in the size. They can be tough to swallow sometimes, in this population. The other thing is some patients, it upsets their stomach when they take it. It doesn't make their stomach feel good. I've heard some patients say if you take it with a little bit of healthy fatty acids with it, like some nuts, you take some nuts, wait 10 or 15 minutes, then take the AREDS, that maybe that can help with the upset stomachs. Um, so, to me, they're not totally, there could be some negative drawbacks to specific patients. I will say I do care about what the nutritional status or health of the patient is, generally speaking, when I'm thinking about this too. I ask the patient about their diet. I say, how do you eat? Do you eat good, healthy, nutritious foods each day that are, lots of dark green leafy vegetables and, antioxidant Mediterranean types of foods? I go, are you eating the typical American diet, of hot dogs and hamburgers and ice cream and processed foods? And if they're pretty unhealthy with their diet, I try to get them to think about a healthy diet, but I also might think about leaving them on the AREDS so that they're getting those nutritional benefits. If they're a very healthy eater, I think about maybe stopping the AREDS if they have advanced disease, and telling them that I think you're getting a lot of those good nutrients by the way that you eat.
Well, this has been a fantastic analysis in an area where there is some controversy. Do you know if anybody is looking at this issue yet? The ARADS group or any other group?
With regards to the wet macular,
Well, no, in terms of the the geographic atrophy question.
like
Uh,
what's coming next here on this
yes,
question, on this controversy?
yes.
Yeah, it's a good point. I think I have not heard of any further analyses that are in development from any recent complement inhibitor therapy, large trials. With regards to the AREDS research group, they may be working on this further. If I can recall, I don't recall further, but I really hope that they do because that work they published in 2025 really changed how I think about AREDS, and really caught my attention. And there really might be something there. And hopefully we can get better analyses here over time. I believe actually now that I'm thinking that the AREDS research group has an OCT study they're working on, so a different imaging modality with different data sets. So with different data. So we might get a lot more information coming from the AREDS research group on this topic over time.
Yeah, OCT imaging is a better way of looking at geographic atrophy than color fundus photography, obviously.
Absolutely. Yeah.
Obviously.
It's it's
So
it's one of
that's,
the most important technologies we have, if not the most.
yeah, thanks so much for a great discussion.